with a grid. So for our knees, we are going to take this cassette and we're going to put it inside our bucky. So this one is going to be at 12. This one is also going to be at 12. Okay. Put it in. Lock it in. And now, because I'm using my bucky, what else do I need to make sure to change?
The IR on the tube.
Very good. Come over here, change my detector setting. Move it from cassette over to table. All right, great. So, now, who is going to be my patient?
Unlucky.
All right, move over Jay.
This is our last set of stuff, right?
Right knee?
Right.
That leg weight.
That's it, yeah, that's the weight.
You have to hit legs.
Okay. All right. So go ahead. So for this one, you do not need to take off the shoes. So go ahead and lay down.
I think he was raising
Oh,
his
pants,
pants.
that's fine.
Oh.
You don't need to take off the pants either.
Okay.
You don't need to roll them up either.
Oh, good
Just
deal.
leave it straight down.
I know.
Keep it PG.
That's right.
I was giving him a smaller one. That's fine. Oh, that's fine? Okay.
Oh, by the way, could you flatten out that yellow one?
Yes.
Thank you.
Yeah, this is the one I was gonna do.
Okay. So,
You a bully.
all right. So because we are using the bucky, what else do we need to make sure of as far as our tube goes?
The red light now.
Yes, that's right. We want to make sure the red light is not on anymore.
That was my lesson.
So how do I get rid of this red light?
The
All right. So we have my D times on, right?
Oh, you
Put
wanna make sure
one-
the you wanna
one
make sure
of
the other green light is on.
I do want to make sure the other green light is on. Which other green light?
Longitude.
Longitude.
Mhm. Yes.
You just gotta match it up.
So, do I have a lock somewhere here?
right there.
Oh no, let's keep.
You have to match it.
Right.
That's
you
right.
gotta go
I
with
did
40.
not lock it longitudinally. Instead, I lined this up with my bucky, just like with the KB. So these line up, but there is no lock longitudinally.
There's no lock either way.
Well, what's the other direction?
Lateral.
Lateral.
Oh.
Did you hear that?
Yeah.
Do you see that?
Yeah.
But what's the problem?
But the
Mm.
dark is still
Exposure holder
on.
still.
It's still red. All right. What else do we need to do?
Oh,
I have no
40?
idea.
40-inch SID.
I don't really feel comfortable doing table stuff. I don't really know how to use that.
Well, then we'll need to find time to practice.
Okay.
Okay. But now, do you see 40-inch SID?
Yes.
Lock laterally. Green light on. No more red light. Right. So our goal is to get rid of the red light. If you see a red light, one of your three directions is off, either vertically, longitudinally, or laterally. In the case of the table, it will not be longitudinally. So you've narrowed it down to two possibilities. Sometimes it's both. Sometimes you need to fix both of them. All right, over here, we've got our laser. So Reagan,
Sorry.
it's okay. Come on over. Since you said you're not comfortable with the table.
Oh.
So, laser, right? Make sure you line it up with the dot right here. So underneath there's a button. Hear that?
Yes.
So there's a button right here. Slide it. Get this lined up. Once we do that, do we ever touch the tube or the bucky again?
No.
No. Very good. If we need to position, what do we move?
The table.
Float the table. Very good. Right? Or we ask the patient to slide up if they're too tall. So, let's take a look at the knees. Okay, so since this is the right knee, I'm gonna ask my patient to slide just a little bit more to the left. That way we can kind of get the right leg in the center of the table. There you go. For the knee, we have 4 of them that are specific to the knee. We have AP, 2 obliques. This time the obliques are medial and lateral. And then we have the actual lateral knee. So, can you turn your leg so that your toes are pointing upwards? Great. Is this truly AP? Does this foot look like it's pointing all the way up?
No.
No, it feels like we still need to turn it a little bit more, right? So, here is what I wanted to tell you about shoes and knees. Very, very commonly, what I see students do is they come over, they're like, oh, this foot isn't turned enough. Let me fix that. And they grab onto the bottom of the shoe and they turn the foot. What's the problem here?
Only the foot rotated, not the whole leg.
No, that's not the problem. Thank you. You're walking around the hospital. What's on the hospital floor?
Everything.
Pretty much everything's been on the floor, right? Blood, urine, vomit, right? Anything. Right? You name it, it's probably been on the floor. Your shoes have been walking all over that floor. So you're telling me you're gonna come over here, grab the bottom of the foot, bottom of the shoes that's been all over that, use it as your positioning guide, then come over here, palpate your patient. If you have a second exam, oh, we also need to do a head. Let me come over here and palpate your head. Oh, thank you. Let me shake your hand. And you're gonna do all of that and pass that on to your patient. No, you're not gonna do that, are you?
No.
Thank you. So, how do you position?
The
You
leg.
grab the leg, you grab the ankle, and you do not touch the shoes. So that is my biggest pet peeve in lab after table height, right? Number 1, always raise your table up. And number 2, never touch the shoes. If you touch the shoes, I'm gonna be staring at you until you figure out what you did wrong, right? I'm just gonna be quiet, I'm just gonna be, can't believe you just did that. Can't believe you just touched the shoes like that, right? Can't believe it's Jamaica, can't believe it, right? So, do not touch the shoes. Now, knees are fun because there's a lot of stuff we need to worry about for the knees. Anyone know what this is?
Caliper or something.
Caliper.
Caliper.
Great.
Yeah.
What is a caliper?
It measures the thickness
Great.
of the
This-
anatomy.
Right, this measures tissue thickness, right? So for example, I can stick my arm in here, be like, oh, okay, my arm is only about 8.5 centimeters thick. Could probably hit the gym a bit more, right? But calipers measure tissue thickness. Calipers are important for the knee. You may not have seen your techs use calipers before, but in lab, you will need to make sure you properly measure your partner. Why? Because knees have potential angulation. The possible angulations depend on the thickness of the body part. Does anyone happen to know the angulations and thicknesses off the top of their head?
For thicker patients, it's 5 to 10 degrees.
Mm.
Cephalic.
All right, you're on the right track. So, for your thin patients, so what do I mean by thin patient? I mean, if I take the shield off and I find my patients as is, so pardon me, there we go, as is right here. And so I go and I measure from the table, roll back, to the top of this as is right here. Okay, so I'm measuring from table to as is. And I look down here. And the line is based on the number on top of the line. So if I'm at this line right here, what is the thickness?
7? 17? Okay.
The number above the line.
Oh, I can see.
So what's above the 17?
18.
18, right? So how thick is this? 18 centimeters.
You get the gym.
Right.
Yeah.
See that? Oh, this at the line, you look above it, it's 18. So, I'm measuring 18 centimeters here. Here, these are the numbers you need to watch out for. If your patient from table to as is less than 19, you angle 3 to 5 degrees cauded. If your patient is between 19 to 24 inclusive, so 19, 20, 21, 22, 23, 24, any of those numbers, you are going to have no angle. If your patient from table to as is greater than 24, you angle 3 to 5 degrees cephalad.
3 to 5. Okay,
So
gotcha.
thin patients, 19, less than 19, 3 to 5 cauded. Big patients, more than 24, 3 to 5 cephalad. Anything in between, from 19 to 24, you are going to go 0 degrees angulation. Does that make sense?
Mm-hmm.
So based on what I just measured, how much angle should I use?
3 to 5 cauded?
Great, 3 to 5 degrees cauded. Make sense?
Yes.
So make sure you measure your partner, because that will determine what angle you should use. If you use the wrong angle, then you're going to be in trouble. So, 3 to 5 cauded, correct?
Yes.
Do I need to change my SID?
Yes.
How much?
If you go to 5, then it
Mhm.
would just be 1.
Great.
Yeah.
All right, very good. Now, I don't know if the table will actually let me change my SID because of the detent.
Did you take the detent off?
Yeah, it doesn't want me. No, we have to leave the detent on. So, so you guys are lucky. As far as this goes, you don't need to worry about SID while you are on the table bucky. You just need to worry about your angle. Okay?
Are you still
Does it work for
entangled?
cephalad? Like if you do
yeah,
it, it
cephalad
just-
cauded,
It won't let you do it?
it won't let you change the SID still.
Oh, okay.
So just focus on your angle while you're on table bucky.
So for test out, do we just say out loud where we're going, like 3 to 5 cephalad to you?
I'll just look at your angle.
Okay.
In that case, I won't worry too much about your SID. As long as your SID is 40, you'll be okay. You don't need to adjust for the angle. Okay. So I angled, I realigned the cassette and the IR. Here, let me move your leg over. Great. So we want to get this knee AP. So how do you do that? You feel for the bumps up here by the femur. All right, great. What are these bumps up here by the femur?
Epicondyles.
Condyles, great. We also do have epicondyles as well, that's true. And we're gonna get those condyles flat, right? Just like we did with the elbow. To do that, we usually need to end up rotating the leg medial about 3 to 5 degrees as well. So, good, relax, relax. Good, hold it just like that. And now I am going to find my centering. So the center of the knee is going to be 1/2 inch distal, so about 1 finger distal to the apex of the patella. Where do we find the apex of the patella? At the bottom, very good. So, find my patella, here's the bottom. I'm going to put 1 finger right here. And so we're just going to be slightly distal to the apex of that patella. Okay, turn, 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 turn. Okay. Very nice. Collimate, marker. And that is my AP knee. All right. Any questions? Oh, wait, I'm sorry. I should have folded this back over.
Well, he's still young, Mr. Fung.
By the way, what time is it right now?
37.
37. Okay.
8:30.
We'll need to speed this up just a bit then. All right, obliques, 45 degrees either way. Once again, make sure you are rotating the leg, not just the foot. So, we keep the angulation for our
I think I'm gonna
obliques.
finish recording. Cool.
Take the whole leg, turn. Right, good. Right. If they need to turn their hip a little bit, that's fine, right? Ideally, we don't turn the hip too much because we don't want to add too much OID. Right, so we just turn the leg like that, and then we recenter. Okay. Oblique knee. Keep the angulation. All you do is turn the whole leg. Right. Doing this will open up the proximal tibiofibular joint. Right, so you're going to take away the superposition up top here. Right, next, lateral oblique. Okay, so onto your back again and just relax your leg. All right, so when patients, don't force it, just keep your leg relaxed. So bring it back like it was AP, and then relax your leg. So when patients relax their legs, right, feet naturally fall out to the side. Like this, it's almost a perfect external oblique already. By the way, there is a trick to checking your obliques. So, this is what you do. You go ahead and you center your oblique like normal. Okay, so half an inch distal to the apex of the patella, straight down the center of the leg. Put your finger right here and look for that patella. See how I can find the sides of the patella right here? Take a look at this medial side of the patella. Is it on top of the line here? Is it on top of my central ray line here? No, I'm over rotated. Take this. So straight down the middle of the leg, right there. Okay, now, middle of the patella, central line coming down the leg. Come this way just a tiny bit, there you go. Now, do you see how the middle of the patella is right here on the line? So now I know I have a good rotation. Right? So, same thing for internal oblique as well, right? The edge of the patella will be about in the center of your image. Okay, any questions? We're okay?
This is the lateral?
Lateral oblique.
Oh, lateral oblique, okay,
Mhm.
gotcha.
This is your lateral rotation. Lateral rotation, right, or external oblique.
Okay.
Okay, great.
And which way is the green strip pointing? Is this way or that way?
Up towards the head. For the knee, always up towards the head. All right, final one, lateral knee. Okay, Jay, if I could have you turn onto your side, please. All right, so in clinic, how do you see your techs do lateral knees? What happens to the unaffected leg? Does it go in?
over?
So it comes in front.
Yes.
Right. All right. Go ahead and bend this knee. So yes, this is the old school method. This is how I was taught lateral knees as well. But I want you to stand where Samantha is. And now I want you to look at the hips right here and tell me what you see.
Or angle.
Right. The hips are turned this way too much. So we always need to be careful to kind of unrotate the hips this way. So crossing the leg over, very, very easy to accidentally over-rotate the patient, over-rotate the knee, and you don't get a good lateral. So instead, recommendation is now to leave this leg behind. So unaffected leg goes back, affected leg comes, ooh, careful, don't fall.
Oh, good.
Okay, so slide your hips forwards a little bit. There you go. All right. So leg comes back, and then this leg, unaffected leg, you bend it, foot flat on the table. Right, good. So to kind of support the patient. Does that make sense?
Yes.
Right, and then over here, we just make sure that we do get a good lateral. Now, before I continue positioning, one more thing I want to point out. Our angle is about to change. This angle was only for APs and obliques. We have a different angle for the lateral. And that angle does not depend on patient size. All patients will get the same angle. What is it?
3 to 5 cephalic.
Close. This one is 5 to 7 cephalic.
5 to 7.
So, personally, I prefer using 7 degrees. So, since I changed my tube, I need to make sure to realign this to my bucky. Okay. Right, so once again, to check my lateral rotation, I can check the condyles, I can try and check the patella as well. So I think I'm gonna have you turn your hips a little bit more. Rotate towards me, turn your whole body towards me. There you go. Good. All right, I'm gonna slide this back. Are you able to move that leg back out of the way as well? Thank you. All right, so down, and so condyle, condyle. Looks pretty superimposed to me.
Yes.
So now all I need to do is worry about centering. For centering, I find my condyle, and I'm gonna go an inch distal to the condyle. Right there. Marker, make sure I have light on both sides. I have patella, I have soft tissue behind. X-ray. Okay. Any questions here? So far so good? Okay. Since we're already here, let's do lateral patella. So this is lateral knee. For the patella, right? Patella is this really tiny bone, right? Or not tiny, but it's the smaller bone here. We are gonna collimate a lot tighter. So, first things first, we actually lose the angulation for the patella. We do not need the angle for the patella. Next up, our centering is now going to be slightly more anterior. So you can feel the patella here, and you see how the patella kind of like dips in right here? So this is that patellofemoral joint. Right? Remember when we talked about
The
like
space.
chondromalacia patellae, right? That space right there. So that is our centering point now. Find the apex, you find the base, you go right in between and then towards the back of the patella. Alright, looks like I'm going to need to slide this leg back just slightly. There we go. Okay, and now we collimate. So patella, I'm going to leave about an inch of light on the top and the bottom. Da, 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 da. And then I have enough light to catch the back of the femur as well. Not the soft tissue, but just the back of the bone. And that's my lateral patella. Very similar to your lateral knee, just slightly more anterior centering and tighter collimation. Any questions here? All right, let's talk about PA patella.
Does that mean I need to be on my stomach?
Ah, great question. I did say PA, didn't I?
Mm-hmm.
All right. So yes, we are gonna have you flip so you are prone. Okay, left leg So yes, we'll do the left leg since that's the closer one. All right, so right now, patella is really close to the board. In fact, it's resting on top of our table, right? Imagine that you had a patellar fracture. How would you feel about resting your patella on a hard table?
No.
Not good.
No. So, what are we gonna do? We're gonna slightly build up the leg around the patella. All right, so lift your leg up, please. All right, so here, here, all right.
Would this not make sense to do it like cross table if they lay on their side?
Hmm. So, can you do it cross table laying on the side? Yeah, that's definitely possible. That's just not the textbook method. Right, so here I try to build up the patient slightly.
You got a little donut?
Maybe a little donut with the sheets.
Yeah.
Yep, so patella now is just slightly floating in the air here. Right, slightly floating. Why do you think we do this prone?
To open.
If we're looking at the patella, why are we PA instead of AP?
Oh, because it's closer to the IR.
Very good. We put the patella close to the IR, we reduce that OID. So that's why we're doing this prone. Okay, this one is actually really straightforward. You do this with your patient, you take the foot, you have the heel come lateral just slightly, right? So you see how the heel is already kind of pointing towards us? That's perfect, we want it like this. And then, as far as centering goes, you're just gonna feel the leg here and look for the crease in the back of the leg. And that crease is gonna be your centering point. So that's the crease. I'm just gonna move this slightly more north so that it doesn't show up in the x-ray. Great. Pat down the clothes.
You're at 4%, Mr. Brown.
Oh gosh. Okay. Well, living on the edge.
Do you have a Georgia in your car?
I do, yes.
Okay.
Okay. PA patella. 0 degrees angulation for the SID and aims right in the crease here behind the knee. Any questions? So far so good? Okay. What time is it?
About 10 till.
Yeah.
10-2. All right, we can do this. So, while we are prone, let's talk about the sunrise. In clinic, you may have seen them do sunrises with the patient sitting in the chair, and then they bend their knees and they put the board underneath. Have you seen that?
Yes.
Yeah.
I've seen
Some of you
I've
have.
seen it on top of the knee as well.
Mhm.
Okay, good. We are not doing the chair method.
Mm.
The chair method is called the Hobbs.
Mm.
We are doing the Siligast. Siligast has 2 methods, prone and sitting. So the one with the cassette on top of the patient, that is the Siligast sitting. We will do that. But first, since our patient is prone, let's do the prone. So, easiest way to do the Siligast. First of all, we are looking at the patellofemoral joint, so we are no longer going to be in the grid. Right, so lift your left leg up slightly. Break back down. So, cassette. Angulation, 20 degrees. So how much am I going to change my SID by?
4.
4, very good. So bring this down to 36. All right, 20 degrees angulation. Patient's leg, straight up in the air. So we're gonna bend that, have it straight up in the air like this. 90 degrees. And then we aim right here, just a tiny bit distal to the apex of the patella. So find that apex, you go a little bit distal, that's gonna be your joint space. Okay, here's my patella. I'm gonna go right here in the middle of the patella. Alright. And then I have my central ray lined up. I'm just gonna adjust my IR now. So lift the leg up just a tiny bit. Lift up just a tiny bit. Yep, there you go. Alright, back down. Perfect. Good. Leg straight up and down. Collimate. Collimate. Which leg is this? Left? Okay, pretend it's the left marker. Right, it would go right here.
That's at the patella.
This is the patellofemoral joint. Actually, Regan, do you have your left marker?
Yeah.
Mind if I borrow it? Thank you. So, right, so that is your sunrise. Apex of the patella, right? So just a little bit distal. That's going to be your joint space. So you're coming in 20 degrees to the tibia. The tibia straight up and down, it's 20 degrees. All right. Any questions? Okay with this?
Yes.
This one I actually feel like is the easier method. Go ahead and relax. All right, and
You use the IR back?
now this time, turn onto your back, supine again. You turn towards me. All the way, all the way.
Yeah, one.
All right, well, guess I just won't be listening to music in the car.
You have a low power mode that you can turn on?
It's been on the whole time.
Yeah, it burns up really fast here. I don't know.
I was planning to bring a charger, but I
What kind of
ended
phone?
up
What kind of phone is
It's
this?
it's an Android, so it uses the
Oh, okay.
USB.
Oh, okay.
Micro
See?
USB?
Cause I'm sad.
No, the USB-Cs.
Portable charger, but it's not for.
Okay. So, okay, I'm gonna have you slide down until you're at the edge of the table here. Good. Keep your feet there at the edge of the table and just bend your knees. Your feet right here. And just slide forward until your knees are at a 90-degree angle. Perfect. Right there. All right, actually scoot back a tiny bit. Yep. Feet flat. Good. So, 90 degrees, right? There you go. Oh, sorry. Are you okay?
My stellate fracture. Ah!
Oh, we'll see. Okay, slide over. Good. So in clinic, you do bilaterals. Right here, we're only going to do unilateral. The idea here is that the leg is 90 degrees. This is 45 degrees. You're going to be 20 degrees off this tibia. So your angle is going to be 115, right? From your 90, you go 25 degrees cephalad. Right, so you're going 25 degrees cephalad here. Just take, once again, just find the apex, being right under your apex. Make this about 40 inches. 39.5, I'll take it. Lift this up just slightly. There we go. Centered of central ray centered to the IR. This is usually really tough, depending on your patient, because you need your patient to hold this for you. Which leg?
Right.
It's my right.
Right, great. So, right marker.
They're not really sticky.
Get the
Here.
It's good. It's good. All right. That is our acetic acid sitting. Sorry. So just aim up 25 degrees, right here under the apex of the patella, and that is your sunrise.
And do you keep this OID to magnify the patella?
So we have this angled to match your central ray.
Oh, I see.
It's perpendicular to your central ray.
Okay.
Okay, any questions here?
Been here. I've seen people just. It was just our last position.
That's our last position.
I'm gonna try this.